quite talented. He's also with Children's Hospital Pittsburgh. He's the medical director of the West Virginia Poison Center.
Yep, down there now.
He's the assistant medical director of Pittsburgh Poison Control Center. So when you call the poison control centers, he's the one in charge there. And then he teaches medical students, residents, fellows of the University of Pittsburgh, and fellowship director for the Medical Toxicology Fellowship. So when we actually fly patients in, and we usually have toxicology patients we're bringing in from area hospitals, he's actually usually there to greet us and see our patients. So it's pretty cool having him waiting for us at the bedside.
Love it.
You should be pretty interesting.
You'll be blessed. If you are here in hopes of learning something, you're in the wrong room. That's next door. Now, last year, Antoine videotaped this. My son still watched the video of how I was making fun of the FBI, apparently. There's no FBI agents in here, correct? Okay, good.
They're waiting for you outside.
My name is Don Yealy. He's anybody asks. I don't know who this Anthony character is. So, anyway, thank you for the introduction. And yeah, we have a toxicology service, which is a little unique for most hospitals at Presby and Children's. So we're always happy for more patients. More drugs, the better, you know. Anyway, so this is one pill that can kill. And it's mostly geared for the pediatric sort of exposures, but you can generalize this for the adults too, because these pills tend to have more potency or more issues with lower doses than a lot of other medications. So we're going to go through a litany of different pills. And you can feel free to stop me if you have questions. If you want to learn something, you may have to stop me and ask questions from time to time. Dave Hendricks is in the front here. If you try to accost me, he'll take you down. Right there, no. Your back is hurting you again, huh? Your back is hurting you again. It's not that. No. Every time we got to move a patient, his back is suddenly killed. You sound like a city paramedic. Oh yeah, turn down the lights. Keep the fruit to yourself.
You might need the FBI now.
Anyway, so mostly pediatric, but you know, we'll go through the litany of medications here. And if we go less than 60 minutes, I hope we won't be upset. But we'll start. A 2-year-old boy ingests a quote antidepressant 20 minutes ago. Mom's concerned. Child is playful, right? His heart rate's 140, blood sugar rate's 20, blood pressure is 122/82, stature 97. He's active. He's dilated. He's like a 2-year-old, right? Anyway, so he takes this. Then what? You say, you call, we haul. City paramedics, right? Glorified taxi cabs.
Pretty much.
Just going all. I found my scapegoat. Sorry, Alex, it's not you. It's going to be the city of Pittsburgh paramedics. Anyway, Wellbutrin. This is one of my favorite drugs. So it's really a sympathomimetic, right? It's much like amphetamine and so forth. It causes reuptake of norepinephrine, serotonin, and dopamine. Now this, I know I'm going to bore you to death with structures, but this is super fascinating. Trust me on this. So this phenylethylamine backbone is the same backbone used in methamphetamine, amphetamine, epinephrine, norepinephrine. So this backbone is very common in a lot of the sympathomimetic drugs. And interestingly, so this is Wellbutrin, and this is cot. You know what cot is, or cathinone? Cot is a plant it comes from, but cathinone is the active ingredient. You guys know what cathinone is, or cot is? This lady's shaking her like, yeah, I know that. I just used it yesterday.
I took your lecture last.
Oh, did you? So she actually learned something. Look at that. So you haven't tried this? Are you sure? Have you guys heard about bath salts? Of course, the city of Pittsburgh paramedics are like, oh yeah. So bath salts, you know, it's sort of a newfangled sympathomimetic. They're not like bath salts from Bath & Body Works bath salts. Don't go snorting those. But they're just a street name for drugs that are derived from the cathinone, or cathinone derivatives from the cot plant, and they put all sorts of different side chains on it and so forth. basically, Wellbutrin is medicinal cock, so it's very similar. Any of these cathino-derived Philipon is sort of the common theme. Again, another sympathomimetic, very long-acting. Why does bath salts give us the most problem? Because it's not like cocaine, right? When you snort cocaine, you got your good buzz. How many knows have used cocaine? You get your good buzz, and then you're pretty much over in a matter of minutes. Well, these drugs, they stick around a long time. That's why we run into problems with these, because they're so long-acting. So, other SSRIs, right? Your favorite Prozac, Zoloft, Paxil, all of these. We're going to back up and talk about these for a second. But in general, the other SSRIs we really don't worry too much about. And that's why it makes Wellbutrin sort of, or bupropion kind of interesting, is that, these have some drug-drug interactions, paroxetine and fluoxetine, and sertraline causes serotonin syndrome quite frequently. We see a ton of these overdoses because everybody's on SSRI, right? Dave is on 3 or 4 SSRIs because he works at Presby. So we see a ton of these and really don't run into any issues. So the only ones that we really seem to worry about is citalopram. Citalopram is Celexa, and escitalopram is Lexapro. These are the only ones with any significant toxicity. They're great antidepressants. Somebody was sharing me the meds that their son is on, and Wellbutrin was one, and Lexapro was the other. And those are the two that we probably run the most problems with, because an overdose, escitalopram can give you dysrhythmias, seizures, tachycardia, and such. And you got to take a lot, though. So it's not one that just one pill is going to cause major issues. One pill in a child may make them a little rambunctious, but not really a big deal. It's really the Wellbutrin we worry about. So accidental ingestions, they can be watched at home. Greater than 5 pills, sort of arbitrary, but more than a couple pills. We would observe in the ED for a couple hours. If they're doing fine, then we kick them out, and then really supportively with benzos and so forth. So the other ones, for the most part, the kid gets into a bunch of Prozac. We don't really do much about that. But and then Wellbutrin, Wellbutrin is name brand Wellbutrin. Zyban has also gone by in terms of like a smoking cessation medication. And like I said, it's a sympathomimetic, right? So you can see all those things that you expect to see. Tachycardic, agitation, seizures, QRS prolongation, sometimes really severe agitation too. So basically, anything over 10 per kilo gets admitted because of even the delayed issues of toxicity. So you can imagine a child then, so you take like a 10-kilo child, a lot of the pills are 150 milligram tablets, 300 milligram tablets. So one kid gets into one of those, they can be fairly symptomatic. And because they're sustained release, their symptoms are often delayed, can be delayed several hours. So everybody greater than 10 per kilo gets admitted. And if you can imagine too, it doesn't take that much for an adult at a 300 milligram tablet, not most Pittsburghers. Like a city Pittsburgh paramedic would take like a whole bottle. But, ooh, now I'm getting low, I'm sorry. That's getting real low. But interesting too, when Wellbutrin first came out, the starting dose, I believe, was either 450 or 500 milligrams sustained release tablets, and they had so many patients develop seizures that they remarketed and gave it a lower dose. So a lot of people are on 150, 300 milligram doses. Wow. So just therapeutic doses were giving people seizures. Wow. So you can imagine it doesn't take much to kind of push you over the edge, especially if you're drunk or whatever else. So, oh, here you go. Here's the weight. So, you have the average weight of a 1-year-old, 10 kilos, 2-year-old, 12, 3-year-old, 15 kilos. And these are a lot of the tablet sizes. So 100 milligram tablet, boom, you're over 10 per kilo already. And you can see you quickly can get over, toxic doses from these standard sized pills and standard kid who's going to get in these meds. So here you go. Here's the case again, right? So it took this antidepressant, which could be nothing or could be very harmful. So that's always the question, right? When it's an antidepressant, like, ooh, is it nothing? Like, can I just keep this kid at home, or is it something serious that we need to really do something about? And I mean, the subtle things, right? Some mild tachycardia, not too bad for a 2-year-old. Dilated pupils, again. So it's all these little subtle things. So if you're from the city of Pittsburgh paramedics, you wouldn't do this. But most other paramedics would probably do something like an intervention of some sort, like check a sugar or something. So we're just using them sort of as the gold standard right here in one.
Wait till he edits this on YouTube. You'll be sorry.
Remember, my name is Don Yealy. Anyway, so he's getting more tachycardic. He vomits, he's more restless, tremulous. A few minutes later, seizure. And typically they're self-limiting, but sometimes can be so long too. So it's always the subtle things that I think we often ignore, that, oh, the kid looks fine, but really get closely monitor the vital signs. You know, so he's a little more tachycardic than he should be. His pupils are a little more dilated than I would expect. And then you know, ooh, that's a little bit concerning. So often, for Wellbutrin, I'm prophylactically giving people Ativan to prevent seizures rather than not seize, because then the medics, you know, freak out, the nurses freak out, right? All those great things. But anyway, so fluids, oxygen, benzos for seizures. So that's Wellbutrin for the most part. I was sharing with somebody else too. We've had a lot of sort of adolescent age PIT students too, because this drug is prescribed a lot. Overdose on it, we've had several deaths from Wellbutrin in adolescent age kids. Maybe they don't quite know the severity of the toxicity, and we're not really sure what's the cause of death, because in several cases we've had, they've had abrupt, you know, asystolic cardiac arrest. They can't be resuscitated, which is in 18-year-old. You'd expect you can get some cardiac activity back, but so it does have some bad things, and by hopefully shutting them down, a lot of times what we do, if you're delirious and really hypertensive and really tachycardic in these kind of Wellbutrin overdoses, we're putting people in under, you know, general anesthesia essentially. Intubate, propofol, shut them off for a while. We think it's the sympathomimetic surge that may lead to cardiomyopathies and sudden cardiac death. And those have been doing better than just sort of like always trying to ward off the intubation for whatever reason, right? You think somehow they are causing harm, but in these cases we're often intubating and just shutting them off in terms of their agitation. Any questions about Wellbutrin? Otherwise, it's a great antidepressant. So if you're on it, don't be discouraged. Keep taking it. This guy clearing his throat is on it. Okay. No question, are you sure? Okay. So another 2-year-old boy ingests unknown diabetic meds shortly before EMS arrival. He's lethargic and vomited once. You can see his vital signs, nothing crazy, uptunded and limp. Again, city of Pittsburgh, they would just haul him, they would just take him, you know, not really do much. Pat him on the head. You're gonna hate me for coming in this room. Normal pupils, clear, nothing else, right? So O2, IV established, again, this would be hit or miss, depending where you are. Sinus rhythm, what next? Don't ask the city of Pittsburgh, because they don't know.
Register the patient.
Take to McGee.
Right.
What room do I go to?
Right.
Someone's got to say it. Blood sugar, absolutely, right? It's simple, it's easy. Blood glucose is 22, so, right, give some dextrose. Now, back up for a second. What about activated charcoal? I know a lot of the EMS people in the room don't have access to activated charcoal, but, you know, in general, would you give activated charcoal to this kid now that he's awake? What's that? He already vomited. So what are you worried about? He's already evacuated his stomach. Anybody else? Who would give activated charcoal? Who would not? Okay. I think that's a pretty good answer. I mean, for the most part, there are, I just bring this up for discuss GI decontamination because it's sort of old school and not really what we do anymore, because we have good treatments. Because there's a decent antidote, it's called glucose. The city of Pittsburgh really knew that they had it in their truck. They could use it once in a while. But, getting deep in here. But, I mean, all the things that we used to do in terms of GI decontamination, we don't really do anymore. Activated charcoal is about the only thing that we do. I mean, there's all this, we get all these stories. The reason why I bring this up, because we have all sorts of people, they love, like, gastric lavaging people at some of these smaller outside hospitals. And I don't know if sometimes they're proud of it because they feel like it's punitive or what, but again, don't do that. There's little outcome evidence and so forth. There's really one study, which is kind of interesting, that randomized people in Sri Lanka, you overdose, you try to kill yourself with oleander. You guys know what oleander is? You're shaking your head like you.
It's a flower and herb.
Yeah, it's a flower. It's ditch, right? The active substance in oleander, it's a beautiful plant, is ditch active substance. So it's a great way to kill yourself. So they make a tea out of it, they drink the tea, that's how you kill yourself in Sri Lanka. Because they have that's just what they do anyway. But anyway, in Sri Lanka, people got randomized to either like nothing, they got caught, or they got activated charcoal. And those who got activated charcoal were less likely to die than those who did not, which is a great study to demonstrate that charcoal can make a difference, but Sri Lanka's a little bit different than here, right? It would be hard pressed to do that study. Maybe we could take a bunch of City of Pittsburgh paramedics and randomize them to do the same study. Oh. No one's laughing. Come on, laugh. So obviously we have antidotes, we have treatments, we have ventilators, we have all sorts of stuff that we can do. So the proven benefits are really not really there. So if anything, we wouldn't do lavage, ipecac, or cathartics. But the only thing we really do is activated charcoal. And typically within an hour of the overdose we would consider. Now if they're vomiting, if they're sleepy, if they're sedate, aspiration pneumonitis from charcoal is really, really bad. So when in doubt, we just don't give it. I mean, the greatest case is, the awake child who rolls in the ED, who may have taken a medicine, like say a beta blocker, to give it to them before they get sick. But if the kid's already sleepy, already vomiting, it's not really a great drug to give. So it gets 4 mLs per kilo of 25% dextrose. He's awake and alert. Meantime, on the suffers, glipizide is the medication, right? So sulfonylureas, which are we still run on these quite a bit in terms of overdose, right? Mostly glipizide, glyburide, the two bottom ones are sort of the most common ones. A lot of these older ones you don't really see too much anymore. But the cool thing about sulfonylureas are great anti-diabetic meds because they help increase insulin release from your pancreas and help reduce your blood sugar. This is a great medicine, but it causes too much insulin release. So if you're not eating, or if a little kid gets it, they can get hypoglycemic too pretty quickly. And the other issue is sort of duration of action down here at the far end. These are the most commonly prescribed sulfonylureas. I mean, duration of action is, in the 24 to 72 hour range. So this is often in situations where maybe like a regular insulin overdose, you get a little glucose and they're better and you kick them out. But these are ones where they may get repeat episodes of hypoglycemia time and time again. So a single tablet can cause hypoglycemia even in a child, even an adult. So even an adult, so this is the carryover from pediatrics to adults. If an adult takes a glyburide who's not diabetic, they get admitted. We admit them all because of the hypoglycemic issues too. So it's not uncommon. Elderly husband, wife, the wife who's not diabetic accidentally takes her husband's diabetic medicine, she gets admitted. The only circumstances are when they're like, I don't want to stay here. And like, well, you're going to stay up all night and check your wife's glucose all night? Hell with that! So then we'll admit them. But sometimes they're really adamant about going home. They can check their sugars and watch them, but everyone should be admitted because even adults get hypoglycemic. Now, so, good percentage, 27% is pretty good, get hypoglycemic. Most are early, some a little bit late. That's the key too. A lot of these get hypoglycemic late. So they may call you to the home as a paramedic, whatever, you check your glucose, oh, they're fine, it was a glyburide, not a big deal. But it may be delayed in terms of what their symptoms are. Most are early, but a lot of them can be delayed. They all need to be admitted because of that delayed onset of symptoms too. So another one, 93 patients, most of the medication that were ingested. Most of the time, median time to hypoglycemia is 4 to 5 hours, but a lot of them, can get hypoglycemic late. And the difference between these studies, the reason why I put these two up is a lot of them are getting prophylactic dextrose, so it makes it even seem like their hypoglycemia is way, way delayed. The practice, which is the study we did, we don't often give prophylactic glucose. We just monitor their dextrose or their serum glucose. And most people were getting hypoglycemic early with very few late, but you still can get late, so they still need to be admitted. So, anyway, yeah, can be masked by hypoglycemia, so basically just admit them all. Admit We don't give them prophylactic dextrose, feed them. We check them hourly while sleeping. The parents love that, right? So we wake up every hour while they're sleeping. We may space out to every 2 hours while awake because, hey, if they're awake, they're probably not too terribly hypoglycemic, and they have to tolerate an overnight fast before they can go home. So if you can not eat all night, like a little kid would, and not get hypoglycemic, then they go home. So they're often in the hospital a couple nights. So, and then glucose, dextrose infusions, you guys all know this stuff, really exciting. The other ones, these are kind of interesting. Prandin and Starlix, if you see these more and more, repaglinide, metaglinide, relatively new medications. They're not sulfonylureas, but they work the same way as sulfonylureas. And the kind of cool thing about these are, like Prandin, we see this more than Starlix, is you take it only right before you eat. So the idea is you get insulin secretion right before you eat. It brings down your glucose right after you eat, and this goes away. Every once in a while, you'll have somebody who takes this and then either forgets to eat, gets distracted, actually has to go take care of a patient, like do a scene run, like you normally, right? And so they forget to eat and get a little hypoglycemic or pass out. The good news is these are much shorter acting, so you give them a little dextrose, we'll watch them for a few hours. If they don't develop repeat episodes of hypoglycemia, we'll often discharge them. But these can cause hypoglycemia too. So they should be monitored for at least 4 hours or so. Any questions about those? No? You're all good? Okay. We're learning something, right? It's okay.